Thank you very much. So this is for the imaging side, and I want to thank Serge also for Dr. Harp to give me some of the slides for this particular talk. So the concept is that whether we should do a TEE or ICE. There are a lot of different ways to do the procedure. So the imaging tools for the left atrial appendage are three. So one, you have to do a CT scan. Two is intracardiac echo. And third is the TEE. And for the TEE and cardiac CT can be used as pre-procedural planning. I personally feel that if the patient has good renal function, it is a good idea to do a CT scan, because then we can see the anatomy of the appendage in a 3D, and we can measure the appendage extremely well. If you have, during the procedure, either you can do an ICE or you can do a TEE or you can do both, and I'll show you some data for all of these things that can be done. Now, in the Cleveland Clinic, as I said, that we are doing both ways, that the pre-procedural planning, we can do a TEE or we can, it is if you do the TEE while we are putting the left atrial appendage, then of course the resolution is slightly better. Temporal resolution is excellent, because in the CT scan, of course, the temporal resolution is a little bit less. But most of the people do the TEE with general anesthesia. I personally like to do the TEE in the cath lab with conscious sedation, and we have been pretty good with conscious sedation and TEE. But again, it is a different kind of a procedure. ICE obviously is easier from the groin. So ICE is intracardiac echo. It's a 10 French sheath with a 3D ICE nowadays. Fairly simple. Of course, no need for general anesthesia. And we need another physician. So I won't say that there's no need for another physician, because to interpret and manage the imaging, you need a person there. And it may be slightly lower resolution currently, and the field of view is a little bit less. And the manipulation has to be done by the same person who is doing the closure. So you have to do two things at the same time. But again, all these things are possible. And of course, you can do both of them. So there are trials. So right now we are doing a trial in Cleveland Clinic where we are comparing ICE and the TEE guidance prospectively. And I'll show you some other data. So if you are going to do the imaging with the TEE guidance or with the echo guidance, the first thing is that we need to know that how, as you saw many, many times, that a 3D imaging is crucial. So if you are going to do the TEE, don't just say that let us do 45, 90, and 120 views. You need to do a proper assessment of the left atrial appendage. And how do you do that is do the 3D MPR. And as you know that this is the upper pulmonary vein, pulmonary artery, left atrial appendage, mitral valve, aortic valve. Very simple. If you are doing this all the time, it is not a difficult thing to understand that what exactly you are doing. But again, you will learn this today, I think, during your lunch hour. The critical thing is that there is the green plane. Typically, we put it as superior inferior. Of course, you can change that. And the red plane is side to side. So the nomenclature that some people use, and this is from Serge, to say that if you are going to use a horizontal, so I always tell the fluoroscopically, if you are going to see horizontal picture, like cutting the chest, that is one view, versus if you are going to do a 45 degrees. So 45 degrees is most commonly what you see is a short axis of the aorta. So that is looking now to the appendage. This is what you will see. And if you look at 135 degrees is a long axis of aorta, and this is how you will see the appendage. So you will know exactly what you're looking at if you have either the long axis of the aorta or short axis of the aorta, where the appendage is, if you have aortic valve in your mindset. So on the other hand, if you're going to do ICE, so first of all, the best way to do the ICE is do the transeptal puncture take out the dilator or the sheath, and then cross through the transeptal puncture and put the ICE catheter into the LA. Again, fairly simple to do. So if you put this ICE catheter, you can do it from the mid-left atrium, or you can go in the left upper pulmonary vein, or you can look from the mitral valve up. All of these different views are possible. I personally think that the left upper pulmonary vein is probably the easiest place to be able to see in most patients. Again, everybody is different, because if the appendage is turned inferiorly rather than superiorly and posteriorly, then you may want to do a mitral valve view. And if you are going to do the views, the best thing again to do is to create a 3D image, and then you can do the MPRs. So again, if you orient yourself that where different structures are, you can turn the image in such a way that is familiar to you, that how the different things are oriented. What are the different things that we do? We check there is no thrombus. That's a relatively simple thing to do. So to make sure that there is no thrombus. The second thing is sizing. And now the sizing can be done, The sizing can be done with the TEE or with the ICE. So again, you can see that the images are extremely similar when you are looking at the images. And then where do you size it? So you can do a 3D reconstruction and size it the two different ways. Some people look for the circumflex to size it. All these things are possible, but again, 3D is probably the best way to size it. And you can compare it to the CT scan if you had done a CT scan before. Dr. Harb has written a nice review article on this particular thing. And again, as I said, that if you are doing it with the 3D ICE, similar concept you are going to use to say that you put the probe just below the left upper pulmonary vein and get the best picture and do it. There is a sizing chart both for the Watchman and the other devices that you may want to know, and that is, as you see, there is a lot of overlap. Many times we like to slightly oversize if the depth allows us to do that. Watchman Flex Pro is the device that we are using these days, almost exclusively, and it has better device. And again, you will learn it today that how the hematological coating is there. There's a 40-millimeter device, and these markers are available such that we can orient in fluoroscopy the device accurately. The larger size is available. So the guidance of the transeptal puncture is also slightly different. So this is the TEE guidance. Again, compared to the MitraClip or compared to the other left atrial procedures, this we like to put it in such a way that it's inferior and posterior, but not too posterior also, depending on where the lobe is. If the lobe is going backwards, then if you are too posterior, you cannot turn it back and make it coaxial. So again, trying to learn so CT scan is super helpful in my mind for this particular reason. And then you can identify again that where we are in the inferior and the posterior way and where the appendage would be. And in the similar way, if you are doing ICE, it's sometimes easier because if you look with the ICE of the septum and the appendage at the same time in the direction from the IVC. So since you're looking from the IVC to the septum and the appendage, you can align it, so to say, straight, and this may make it somewhat easier. And then the next step is to say the deployment. So this is how we do it. We open it, and then we push this little ball. And then, so this is a fairly simple procedure these days to do this. And you can watch all of these things on the both fluoro, ICE, this is the TEE, ICE, and they look very similar. So it is very hard to know what we are doing. And you can correlate it with so again, after we deploy it, this is the ICE picture, this is the TEE picture. Again, this is definitely clearer, and this is a little bit less clarity, but still you can see most of the things that you need to see with both of these devices. And so all these different steps, and then after you do all these things, you try to look for the leak and overhang and stability. So you will do the pass criteria. This is the very important thing that is anchored, the size is appropriate, seal is there, position is of course correct, and then you release it and then you analyze it. So if you look at and finally you want to make sure that you didn't create a problem, so look at the pericardium. And again, both of these devices are fairly easy to look. From the SURPASS registry, we did this study to say the intracardiac versus transesophageal echo. Interesting enough that in United States, out of the 31,000 patients, 2,000 have just had the ice. So this is one thing to keep in mind. The procedural time and, procedural CT was done, procedural time was, I think a little bit same. All other things were similar. But the pericardial effusion rate was higher with the ice use. So this is something, so pericardial effusion is here. Pericardial effusion rate was higher. And again, this is not very 100% clear why this happened, but this is what is something to keep in mind. Now, it is extremely rare with the Watchman ProFlex to have a pericardial effusion. So maybe this is because of the classic Watchman device, and maybe, but these days I personally use the ice if I can. There is also a good article to say that you can do a completely minimalistic, so you do the ice, conscious sedation, discharge the same day, and this is possible. This is what we are doing most of the time. This is an article from Tampa that they reported. And again, they do have some complications that are a little bit, in my mind, higher than what we would expect from the current data. So I think, to summarize, the 4D ice is a reasonable alternative to the TEE. You have to be proficient of, both, first of all, the LAA occlusion and also with the ice, and you have to have a good imaging team. So if you cannot do it, get good pictures, you can just go ahead and anesthetize the mouth and put the probe, again with conscious sedation. That's what we have been doing. Pericardial effusion were more in the national registries. And very importantly, I didn't show you that, but most of the ice cases were done with general anesthesia in the United States. So that doesn't make a lot of sense that if you're going to do ice, there is no need for general anesthesia. So thank you.